So, good evening, everybody. I'm so glad that you're here on this quite hot day in the Bay Area. I'm Ranak Trivedi. I want to welcome you to the fourth of our community talk series as part of our partnership between the SAFAD study and CWC, supported by Sukham and Stanford Center for Asian Health Research and Education. Today, I'm going to start off by sharing a little bit about our project. And then Narenji is going to talk a little bit about CWC's role, and then we'll start the panel discussion. Many of you might have been expecting Dr. Carl Lorenz to be a moderator. Unfortunately, he's dealing with a family emergency, so I'm very obviously not Dr. Carl Lorenz. And I will be moderating and hopefully do it justice. So I want to share a little bit about this project that we've been working on for some years, which is the South Asian Family Approaches for Diseases study. It's a project that we started a few years ago with the main goal of understanding what are the unmet needs of breast cancer survivors and family caregivers of South Asian heritage. And our first step was just to listen. So we talk with a lot of people, talk with clinicians, we talk with survivors, we talk with family caregivers. And one theme that came up over and over again is that people were looking for a space to connect with one another, because we know there's a lot of stigmas and taboos associated with cancers in the South Asian community. So we heard that. And then we also heard that people were interested in learning from a variety of experts about these different topics because they don't know who to go to, they don't know who's gone through these experiences within the community. They wanted to have a space where they could hear. So that has led to the panel series that we've been doing in partnership with multiple people here, and Narenji is going to talk about their role with this. As we move this discussion forward, our ultimate goal is to develop programs that are culturally attuned for our communities. So we have been doing other work. We did a co-design workshop as part of our study. The first one we finished a few weeks ago, and we're planning to do more, so stay tuned for that. And we love that you're part of this dialogue. What we will be doing today is we'll have a moderated conversation. We'll have from our panelists here. We'll be recording this, and that will be available later for you and just available online for people to access. And then we'll open it for question and answers. So for the Q&A, we will not be recording the Q&A so that people can ask whatever questions without having to worry about who will learn that they attended this session. So with that, I will hand it over to Narenji to say a few words.
Good evening. Can you hear? So I'm so delighted that something that was needed in our community is happening. So I've been part of Indian community for a long time at ICC and CWC. So in 2018, we started this movement called CWC for health and wellness. Our initial focus was metabolic diseases, because there were a lot of issues, as Neelu will tell you. She's part of Kaiser. So a Kaiser doctor, Pankaj, joined hands with me and we started that. Last year, when we did a survey of our community, fortunately, the need for those kinds of things has declined, because a lot more people are educated as to what is the right thing to do and also even how to reverse it. Unfortunately, the two top issues that are now front and center is what she was talking about, cancer. And same thing true, a deeper way, for women wellness and mental and emotional health. So what you'll be hearing today is very appropriate, in the sense that when somebody gets struck with a cancer, biggest difficulty is not medical initially, it is emotional and stress and medical health. So in Bay Area, just to give you numbers, we have about 600,000 South Asian. About at least 100,000 of them are struck one way or the other, patients or caregivers. And they are very pained. And what she said just about stigma is one of the issues. And there is a reason some people don't want to share. So Neeluji, you have done a phenomenal job. Mukund, I've known for a long time. He's doing a good job. And So I'm here only to say that it's a great partnership between Stanford, which we have had in multiple ways. And by the way, there are about 90 people that registered on Zoom, all the way from India. So many people are going to listen today and then on YouTube. So thank you very much.
So today is a topic that I think affects a lot of us. It's a topic is around pain. I have some notes here, which is what I'm referring to. The pain is a big part of cancer, and we often think of pain as associated with medical treatment. But we know that pain is affected by our beliefs, our cultural context, our mental health, our social context, and certainly, of course, the biological context. So today we're going to have a conversation about the misinformation, the taboos, and the myths in the South Asian culture around pain and pain management. We have three experts here. With each of our panels, we want to make sure we elevate both the clinical expertise as well as the lived experience expertise. So if we can, I'll have each of you introduce yourself 2 or 3 minutes briefly and your connection with this topic, and then we'll start the discussion. So go ahead, please, Mukund.
Thanks, Ranak. So my name is Mukund Acharya, and for those of you who were in session 2 earlier, where I was also on the panel, some of this will be repetition, so excuse me for that. Briefly, I like to say that we're all the product of our lived experiences. And until about a dozen years ago, I didn't think I'd be sitting here or do what I'm doing now. But for about 41 years, I was in the aerospace arena, an academic, researcher, technology development. I worked in industry, government labs, and academia on 3 continents. Along the way, life has its way of having us make mid-course corrections or sharp changes. In my case, the experience that transformed my life is having to be a caregiver for my wife Sandhya, who's no more, and being a caregiver for her over 7 years. Had a transformational experience on both of us, dealing not just with the disease, but with the medical system and the environment. And after we lost her about 12 years ago now, I decided that I wanted to give up engineering and didn't know what I would be doing then, but do things that would be of value for patients and caregivers in our community. So over the past 12 years, I've sort of developed a new career, if you will. And among other things, I founded a couple of nonprofits. There's a nonprofit called Sandhya's Touch, which is legacy to my wife. I also co-founded an organization called Sukham, and Ranak mentioned Sukham. Sukham is one of the partners in this program. And delighted that my colleague Neelu here is also a member of Sukham. And what we do at Sukham is we don't do any direct service. We educate, empower, and enable people to live and deal with all issues related to aging, including dealing with illness and death and bereavement. I'm also heavily involved with Stanford Hospital over the past dozen years. I'm a patient family partner there. I provide various direct services to this in spiritual care. Plus, I do other things like I've been in a community advisory board member for Ranak's SAFAD program for several years now. And so in this context, I'm able to learn new things from the community and grow as a result, but at the same time share the information and resources and knowledge to help other people in big and small ways. So.
Thank you, Mukund, and thank you for serving on our advisory board. Neelu.
Thank you, Ranak. I'm Dr. Neelu Mehra. I'm trained in family medicine and palliative medicine, and I lead the program at Kaiser in Redwood City. And palliative medicine is a field that kind of walks alongside people who are dealing with serious illnesses while they're pursuing their treatment so that they can have the support that they need, not only symptom management, but also from the holistic perspective, like culturally, socially, and from spiritual standpoint. So I'm lucky to be leading this program at Kaiser, not only in the palliative care space, but also in the entire continuum, which kind of spans outside the hospital, where the care looks like, how it looks like in home health and home-based programs, in transitional care programs, in skilled nursing home. So I have a viewpoint of how the journey starts from the clinics to the hospital to the entire continuum. And like Mukund said really well, that your lived experiences shape you the way you are. And having some experiences in my own life attracted me to this field and brought this my passion to this. And I'm lucky to be serving in this field and happy to be here with you all today.
Thank you, Neelu. And last but not least, of course, Sunny.
Yes, thank you. I'm Sunny Dosanjh, and delighted to be here. Share a few thoughts from my lived perspective. Currently serve as the chaplain for the American Legion, Santa Clara County and the Bay Area, Monterey Bay. I'm an American Legionnaire, so we are veterans of the United States military, and also a Royal British Legionnaire, where I was born and raised in London. And so I share that because what I've seen through my lived experience over a decade, sitting in hospice with veterans, World War II, Korea War, Vietnam War lately, being captain of the honor guard, doing services for their family. It's a humble duty and an honor. And a lot of the senior veterans, because of their battlefield experiences, they've accumulated diseases that manifest in different ways. So there's a pattern that evolves, not only with PTSD, post-traumatic stress disorder, but persistent complex bereavement. I don't like the word disorder, but we call it grief. And the third one was soul injury, a moral injury. So this aspect of sitting by veterans with their wives or significant others, their children, over the years, something emerged. I couldn't quite place a vocabulary on it, but there was a space allowed for this conversation to take place, to have the veteran share with what was actually going on. It's a safe space. And the vocabulary, the reason why I mentioned Royal British Legionnaire, hospice started in England, so we started using the English vocabulary translated to the American vocabulary to see if it meant the same thing. How do you show empathy and care? Parallel to that in the Indian community, I do tours at the Sikh Gurdwara at San Jose. And I see a lot of folks talking about cancer privately because they know I'm a chaplain. And I see young children passing away. I see elderly passing away in the Indian community of cancer, but they won't talk to anybody about it. So I started seeing the parallels. So I called it a language for something that has no language. How do you introduce the space, the vocabulary for having that conversation, at least the initial steps? So I started with poetry. I started to opening this up to provide an actual avenue to have that expressed for something that you may not even know where to start, especially when you're a child or an adult, or in our case, military veterans. We don't say anything to anybody. So I saw the parallelisms, and I've been fortunate to have been in Silicon Valley for about 40 years. So I know a few guys in tech, myself being one of them. So we're looking at the tools that can help us and augment that vocabulary and then help those who need it the most, give voice to those who have no voice. So I'm grateful to be around folks who have a perspective that I can learn from, and then hopefully we can help folks in the community. Thank you.
Thank you so much, Sunny, and thank you all of you. So I'll start my first question with you, Neelu. From your clinical expertise and experience, can you share some of the barriers you see in the South Asian community around pain and pain management?
Thank you. That's a great question. So, in my experience of 20 plus years of working in this field and dealing with a lot of South Asians in terms of their cancer journey, the pain management, I see a few barriers that come out. And one is the cultural expectation. We're very stoic people, and we believe that suffering adds to our mental resilience and our spiritual strength. And we are very protective of our families. We don't want to put them in any harm stress. Even though I may be in pain, I don't want my daughter to know that I'm in pain because I don't want her to worry about me. So a lot of the times it's under wraps and it's underplayed and underrepresented. And then the second thing is that we we are reluctant to take medications. We don't, and pain medication is a tall order. We don't want to take medications, period. That what it will do, it'll cause side effects, or I may get dependent on it, or my body will get used to it, and I won't be able to do things without it. So I think that's a bigger barrier that I notice. And we just don't want it. We go default to other modalities like homeopathy or Ayurveda, and there's nothing wrong with it. But I think coming to a juncture where you can blend the two would be a great way to go, but I do see some resistance towards it. And we can come to the Western side of it only if these things didn't work. And a lot of times it's a blend that works the best, not just that. And then I see some communication gaps, if you will, because being stoic, we underplay our symptoms. We don't say it the way it is. And if I didn't have a cultural lens to it, I would just take your word for it. And I feel like, oh, your pain is a 2. Okay, we don't need anything. Whereas the pain is at a 10, and we do need intervention. The quality of life gets compromised a lot. And I think the last thing that I see as a barrier is that we view mental health as a taboo. We don't want to get help. A lot of the medications we use for pain are actually used also for mental health. But the use case in pain management is very different. And if we're using those medications, we don't want to tell our family that we're using medications that are used for depression because I'm not depressed. So I think that holistic perspective of pain gets missed, and we're not able to do justice to symptom management as well as we could do if we had more leeway to play with.
One of the things that my mom had advanced breast cancer for many, many years, and also had a lot of reluctance to take even Tylenol. Forget, you know, prescription pain medicine. What are some taboos or stigmas you see around that is keeping people from doing that? You mentioned some of the stoicism and those barriers. Do you see those tensions there as well? Where what are they worried what'll happen if they were to take the medicine? What is the consequence of that?
I think they worry about the side effect. My body will get used to the
Sure.
medication. And I think the biggest barrier that I see that they have a taboo. They don't want people to know that they have cancer. They don't want people to know that they're taking medications which have these big names and people will raise eyebrows. We care about our community. We care about what people think about what we're doing. I think we compromise ourselves in the midst because we don't want people to understand things that may have a certain judgment on us. So I think that what I see is the biggest barrier. We don't want to tell people that we are dealing with this issue. And if I was taking these medications, and heaven forbid, if somebody knew that I also am dealing with cancer and I have these pain needs, that becomes a social barrier, in my opinion.
Yeah, thank you for that insight. And we often talk about barriers, but I'm also wondering, Mukund and Sunny, if you have come across success stories. Have you seen times where people have embraced the pain medicine or pain treatment? Doesn't have to be medicine. It could be behavioral treatment. Does any of that, can you think of examples of how might people have navigated that?
Would you like to?
Yeah.
Yeah, it's the number one thing that I see that I'll speak at it from a veteran's perspective, and then I share with you how it goes into let me just turn this off, from a family perspective in the community. Number one thing for us is trust. Do I trust just a look in your eye. You don't have to say a single word to me. Do I trust you? Your vibe, your aura, your presence. So whether you're drawing from faith-based stuff, metaphysics, pure science, the vocabulary costs those. Are you mixing and matching a soup that's alchemic in nature and feeding me something that's not good for me? It's good for my ego. It's not good for my soul. And it's not good for my condition. Take 3 of these, do 2 of these, do 3 Hail Marys, or, do this, that, and the other. Okay, you read that in some manual. Maybe your new AI chatbot helps you out. But do I trust you? And so what I found for recovery, for those who, at least on the path to recovery, who survive stage 4, is don't give me this Pollyanna stuff that everything is hunky-dory, everything is positive, it's a pink cloud. It's do I trust you? Have you walked down this path, or have you helped others walk down this path? Can you provide me that space? Okay, now I got something positive. Now I've got a rock, an anchor. I know you're going to walk with me. I may not heal, but I'm going to trust you to be there. Good, bad, right, wrong, up or down. You're going to walk this with me. I trust you. And that gives me hope and confidence to at least take the next step. If that's medication, if that's praying, if it's just getting up and eating something. From my experience, that's what I do. Time will tell if it helps the person, but at least in that moment, they know they're not alone. So that's the approach that I've taken.
Yeah, that's a great point. Yeah, thank you. Did you want to add anything
so-
too?
Yeah, I would say just to start out with all the examples that Neelu talked about on the failure side of things, if you will, define that as opposite. It's a success story. I've seen that anecdotally in the community, and we can certainly talk to that more. But one success story I can relate to was my wife Sandhya's. So she had an aggressive form of breast cancer called triple negative breast cancer, and she underwent surgery followed by focused radiation followed by chemo. I think the success lies partly in the complete trust and faith we had in each other. So we were able to share our thoughts in an unfiltered manner, knowing that we would respect one another's opinions. Sandhya tended to be a data-driven person when it came to things like that. She was also very emotional and artistic in different ways. And she would ask why. So if the doctors could explain why certain treatments, certain medications were necessary, were prescribed, she would go ahead and we would consult, and she would go ahead and work with that. She also believed in addition to what we would call the allopathic regimen, she also believed in forms of what I think is commonly known now as energy medicine. So she believed very strongly in the power of pranayama, of breathing. She believed in the power of meditation, bringing and I think there's a lot to be said for the mind-body interaction. So just another aside, when we talk about pain, it's not just physical pain. There's the emotional pain that we have to deal with, which in turn can impact the physical body. And she understood that she could get relief from what we call complementary therapies here. So she practiced a daily form of breathing technique that she'd learned, and she practiced meditation, and those coupled with the pain medicines brought her quite a bit of relief. Later on, when after she went into metastasis, and she was recommended more powerful pain medications, she also reached out to and found some comfort in techniques like the healing touch, which some of you may be familiar with. So I think the ability to, I guess, deal with your pain using multiple tools at your that are available to you was something that she recognized and followed through on it.
So if I may add on the positive note, that a couple of patients that I had some positive interactions, and is like Sunny said, is building trust and building rapport. You have to build bridges with them, not create walls, and you have to start with understanding where they're coming from. So I had a patient who was not willing to go to the pain medication, and then asking her, okay, what is it that you would be willing to do and how do you help yourself? So she told me she takes turmeric in milk, and that's what she's doing. So then I asked, okay, well, will you be willing to take turmeric pills? And maybe we can start off with that. So that created a point of trust that, okay, I'm willing to listen. I'm not throwing in medications and saying, well, this is what you need to take. I'm open to the things that you're open to. So then we started the turmeric pills for a few days, and of course it helped some, but it didn't help all the way. And so we said, okay, are we willing to try something else? So she was willing to try the next level, which was the weaker opioid. And I explained that what that's going to do. We got that. And ultimately, we were able to get to a little bit of morphine as needed. But there was a trusted rapport that was built along the way. And then the other patient I had, she was, no, I'm not going to take anything. So I said, what do you do when things are getting tough for you? She said, well, I do breathing exercises and I meditate and I love to read. So I said, is it okay if I gave you a book to read? I can give you some recommendation. So I gave her a recommendation of a book that kind of talked about a certain meditation technique and mind body practices that Mukund talked about. And she was able to get really into the book. She adopted some practices from that book and was able to do meditation every single day, and she didn't need the pain medications. So I think working with wherever they are at, where the journey is very important, and identifying what's important to them. And versus telling them what to do, you have to elicit the point of view and see where this can lead you together.
I love all the examples that all of you have given because you've talked about trust, you've talked about communication, and you've talked about being creative. And when you build trust, there is this walking by the side and listening. But also, what does it listening look like when when you're there to provide clinical care? And how do you ease somebody into a treatment? And of course, we know that pain is more complex anyway, that everything is more complex than we think. But pain, obviously, there's a lot of ways in which people can manage pain. It could be distraction, could be uh, like the reading, could be meditation, could be behavioral, any of that. So I love all these examples that we're getting. One of the things that I'm always curious about is how people might be how families and the patients navigate that and what people see. You gave a beautiful example where how you and Sandhya talked and that how were you able to navigate that. On the flip side, we've heard from our study participants that sometimes the patients wants to take medicine, but the families don't want them to, or vice versa. Neelu, maybe I can see if you can speak to that a little bit and see how do we get them to be on the same page. So it's not just trusting you, but kind of getting them on the same page on that.
You brought up a very important point, and I've had a lot of patients who are suffering and who are willing to take the medications, but they said, my son doesn't want me to, or my daughter doesn't want me to. So when I started to explore a little further, they were worried. There was a worry about taking these stronger medications and losing them, right? There's some misunderstanding, a notion in their head that, oh, she's going to become an addict, she's not going to wake up, and she's not going to be able to be alert enough to talk to us, and I want my mom the way it is. So how we navigated this first is to build trust with the patient to even elicit that what is the barrier for them to not take the medications. It's not easy for us to say my son or daughter is not going to let me do it, right? So when you get to that point, that we've had meetings together and explaining to them that what these medications can do, and giving them the freedom that it's not a one-way street. You can retreat, We can stop these medications at any point if you didn't want to, or if it didn't agree with you, or you thought, and then giving them assurance that we've done this for a long time and we're open to different modalities. I've introduced acupuncture, acupressure, yoga therapy, and other things, and you can do simultaneously. Chanting, that's very well adopted in Indian community. Ultimately, you bring in the total pain concept and say, it's not just the medication that's going to help this. We can bring in all these modalities, and what's left over as a physical pain, we can use these medications. And would you be open in trying with me? And if you said, no, this is not what I want from my mom, so you can see instantly there's a relief on the patient's face that they're open. It doesn't happen in one go, but multiple conversations need to be had so that you can bring them along and assure them that this is a path that we're traversing together, and we're there all the way, and we can go on it or decide not to. So I think that empowers them, and it gives them the control and the freedom, and alleviates their fear, if you will, so they're willing to walk with you a lot more safely.
Could I add to that?
Yes, please, of course.
So a couple of things come to mind that I think would be useful to in this context. In one instance I know about, again, it's a misconception that drives this behavior, but there's a family member, there's this patient who started to feel an increase in her pain, and she associated the increase in pain with a worsening of her disease, which is not necessarily, which she just assumed pain's getting worse, so my disease is getting worse. And she didn't want to share that information that I'm getting sicker with her family. So because she was wanting to withhold that information, she misreported her pain basically. And so that can happen. So this not understanding what's going on, and believing the wrong things can motivate behavior.
That leads to underreporting to the physicians too.
Yep.
Because they're just scared to even tell you, because then you would think, oh, the disease progression is happening. And that's a way of coping too.
And the other quick point is on you mentioned trust and communication. One of the things I've also observed, and perhaps some of you have observed in our South Asian community, maybe it's true in many different communities as well, but I'll comment on this one, that when you share some information about your illness outside your immediate family circle, all of a sudden you have 10 different community experts telling you you're doing this right, you're doing that wrong, don't go to this doctor, go see that person, so imposing their quote unquote expertise on you, and that can be emotionally devastating for people.
Right. It is. If I may, in the Sikh culture or the Indian culture, Desi Lodge, right, the witch doctor version, or the grandmama's version passed down, but it's in Indian language. When you try to translate it into English, which English? So even the subtlest, slightest misinterpretation can go down a wrong path. And that's why I started with the context, the vocabulary, because as I try to find common ground to build that trust, I find two avenues that work for me. It's food and music. So tell me what an onion is. Tell me why you use that turmeric or the garlic. What specifically are you trying to achieve? It's like a music symphony of taste buds. So they'll describe it, and then you can kind of get a gauge of where their translation is working. Same thing with music. Is it too much drums? Is it too much piano? Is it too much this instrument, that instrument? You get a sense of traditional Indian music, the classicals, and you get a sense of their rhythm, the way they want to have a conversation. So meeting where they're at, with their vocabulary, with their understanding. So that trust on common ground allows the next words to manifest. And as I mentioned, I use poetry. I use that because it's a story about butterflies. It's a story about nature. It's not talking about their pain, their suffering, but it allows them to open that door using food as a pathway, music as a pathway. It's non-threatening, unless you put too much spice. But that's for another time. But you get the idea. I use that with veterans, different music, different eras. So when I talked to my mom and my uncle as he was passing away with cancer. I talked to my Indian friend today who's in cancer surgery. Do you want to talk? He goes, no. But then I changed the subject to something not as serious, a little more levity. The smile. It's a sunny day in California. Tell me about some good days that you had. And all of a sudden, he forgot about his physical pain. I took him mentally somewhere else. Doesn't mean the pain's gone away. But temporarily, trust, common ground to when he or she is ready. Then they'll say the real stigma or the barrier as to why they do not want to go down a certain medicinal path or treatment path. That's one approach, but that's an approach I've been using because it's kind of like easy. Hey, food, music, what's not to like?
Yeah, and I think you make a really, I think I interrupted you, but you made a really important point. I just want to point out that this, the technique that you just mentioned, or the strategy of just listening, and you don't have to talk about the pain. You can talk about anything else. That's something that even as family or loved ones, as we're being around somebody who is dealing with cancer-related pain, you don't have to be a chaplain to use that technique. That is how we can support one another, even as they're struggling to say. And I think a lot of people shy away because they're like, I don't want to talk about the cancer with this person, so I'm just going to avoid talking with them completely. And then people find of being isolated. What is the term? Cancer ghosted? Yeah, right? Cancer ghosted, right? I just learned this recently, where people just kind of disappear because they don't want to talk about the cancer. But turns out you don't have to talk about the cancer. Cancer is only one part of somebody's identity. But you were going to make another point, Neelu.
Yeah, so a patient of mine had come in and say, if I talk about this, and that means I'm magnifying the problem. It's coming back more fold to me. So that was fascinating for me to hear because if we're talking about the thing, it may happen, and I don't want to talk about it. And you're so right, because if you go outside and if your friends are only talking about the cancer that you have, they have some kind of a sympathy towards you, it becomes fatiguing. And they say, well, I don't want to talk about it. I don't want to even go out with my friends because they look at me differently. So that's also a thing that to keep in mind, that and brings a point to talk about different things. Act normal. Treat them as normal. They're not abnormal just because they had this disease. And those are the hesitations that they carry all along.
It's an identity changing disease, right? If I have diabetes, I'm still Mukund, right? But if I tell somebody I've got cancer, their identity, Mukund as he was, changes in their mind. It's no longer the same.
That's right.
Same thing is true of a lot of mental illnesses and neurological issues too.
And Mukund, just picking up that, you made such a great point, is that you're talking about we've been talking kind of cancer-related pain as the disease, but then there's the emotional pain that comes with having cancer, having a loved one with cancer. I had a meditation teacher who used to say, suffering is pain multiplied by resistance. So you have the pain, however you want to say it, but then when you resist it and not manage it, that causes suffering. And I know, Sunny, you've done a lot of work and in other types of pain outside of this, especially with veterans. And I'm wondering, you've touched on it already, but what are some parallels you see when you think about cancer-related pain and the pain that either is trauma-related or other emotional pain of the people that you work with closest, if you want to
Sure. I think
touch
it's
on that.
in the Indian or the South Asian community, it's a trifecta. You've got the South Asian heritage of what that means in each individual faith group, culture, state. And then you come to the Western world, And now you've got that vocabulary and layer of interpretation. And in military terms, especially I can speak for the men, we're stoic, we're warriors. We don't care about any pain. We don't show it mentally, physically, because we do not want to be the weakest link. And if you look at the heritage of males in general and societal, if you look at heritage, South Asian, Indian males, similar. You want to be the leader, the provider, and so stoicism, any stigmas that come with betraying that role, that persona, it's not looked upon kindly, or at least historically. And in the military ranks and veteran ranks, it has its own narrative to where you do not want to be the cause. And I'll speak for veterans. You do not want to be the weakest person in that chain of command that lets your fellow military person pass away or get injured because you were not strong. That's the mentality of the warrior. Now you put that into civilian life and just being a man or from South Asian culture, and that's what I call, you've got it piled onto you. So how do you navigate that existing terrain to allow an alternative perspective to saying, in the military world, say, stand down. You're no longer on active duty. As veterans, we have to turn that off. We can't. So guys like me and others who provide that safe space, that common ground, to allow that language to unfold, for them to even utter, man, they may phrase it, my soccer team's having a tough time. No, they're not. They're in first place. What are they really talking about? They're trying to break that barrier without breaking themselves. So when you look at South Asian men, I can speak to the Sikh community. We're warriors. We're trained and drilled that way. Do not show weakness. And so to break into that, there's a middle ground. I think the language is evolving. That's why I'm really excited about these groups, because there is a breakthrough. I can see it happening in real time. I can see the warriors and that mentality of the warrior kind of saying, I extend my hand. Can you help me? Because I cannot walk this path alone. That takes courage, real courage. So we provide the space for that courage to emerge.
Thank you. Yeah, go ahead, please.
Speaking of language, I learned a new phrase here today from Sunny. Thank you. Soul pain. So it's the pain of the soul. I don't know quite how I'm going to think about this. I don't know quite how you describe that more. But I mean, think of it as an emotional pain of some kind. And when we're dealing with pain in this context, I think we, the community, the physicians, everybody need to understand what different kinds of pain, what impact they can have on a person's health. So
We call it existential pain. Yes. Yeah. Because just because you're dealing with things and it's life doesn't look the same and you're suffering through it. So pain gets compounded. If your pain physically is a 2, it could be a 8 because you have existential pain that you have not, it's unresolved. So
That's the resistance.
that's a resistance, totally.
So, Neelu, I'm curious, have you seen do you see gender roles or gender identity play out as you think about the South Asian community? Sunny mentioned, men especially being stoic, and certainly that's part of the South Asian culture. I'm curious if you've noticed any gender differences.
I was actually thinking about that when Sunny was speaking. What I've seen is that males take a predominant role. So when it's them dealing with the issues, they're in charge. They will not do certain things. They have a point of view about things and they will just not relent. But when it's the counterpart, they're still in control and they are actually deciding what this person could have or not have. So, and breaking that barrier sometimes takes a lot of perseverance and patience and multiple conversations because we also believe in hierarchy in South Asian community. So like I was with a person who was older and he just wanted me to do what he wanted me to do. And it took me time to break through that and say, we will do it together. And it's not about what I want because I want what you want. And how do we play it out? So that's how I see gender roles emerging in South Asians, which is very intriguing to me. I have not had very many patients who can say, I want this for myself. They look to know he will tell you what my needs are. So, yeah.
Switching gears a little bit, one of the questions we often get is what are community resources that can help? So obviously, Mukund, you're with Sukham and others. Can you share a little bit more of what Sukham's role? You already touched on it earlier, but now specifically in the context of the topic we have and other resources that people may want to look to.
Sure. So Sukham is a very small all-volunteer organization. We formed as a group about close to 10 years ago now. And a couple of things we are clear about. We do not do any direct service. But so I like to describe what Sukham does with what I call the 3 E's. We educate, empower, and enable community members to meet or find solutions to the problems that they come to us with. It's been a process of building awareness and trust in the community over a period of time. But now I would say we routinely get half a dozen calls a month. People will reach us through the website, or I'll get a phone call saying, so and so told me about Sukham and you. Can you help with A, B, C, or D? And there are some areas where we find difficulty in finding the solution, but by and large, we're able to connect people with um, others who would be able to actually address the problem for them without getting into specifics, or we can actually sit and talk to them about giving them a certain body of knowledge and saying, based on this, you can now make decisions. When we recommend, we don't say this is the best doctor to go to, but we will say pick a doctor who has all these characteristics that will help you. And in that way, I think we're not boiling the ocean, if you will. It's a small operation, but we're very effective, I think, in meeting the needs of people who come to us.
I feel knowledge is power. So I think what you provide is information and connection in the community so that they can get what their needs are be met.
I'll give you one example. I'm trying to be a little vague because I don't want to talk about specifics, but I got a call a while back, and this is a gentleman who said, well, we just came from my wife's oncologist, and my wife thinks at this point there are no more treatment options that are realistically available, and they recommend we consider hospice. So I actually went and visited this couple in their home and talked to them about what palliative care meant, what hospice meant, what their options were, and suggested that if I were them, these are the criteria I would use to decide what steps I should take next. And based on that, they were able to find the support they needed in her last days. Didn't hear from them for a while, and then one day I got a text from a gentleman saying, thank you. So I don't know what details, what the actions they took afterwards, but clearly the information I provided was a good way, gave them the boundaries they needed to make decisions for themselves.
Thank you. And I also want to, so the community resources that you mentioned is really important. There was the other piece of it that I think also is which a few of you, I think all of you touched on, is the mental health aspect, because we know that pain management can have a strong behavioral component, and there are evidence-based psychotherapy, cognitive behavioral therapy that are also really effective in managing pain. And since that hasn't come up, the clinical health psychologist in me wanted to also share that.
Totally.
And there's you can have referrals for that, and again, it falls under the double taboo of pain and mental health treatment. And yet there are strong evidence based, just like with acupuncture and acupressure and distraction and coping and certainly pain medicine. You can have psychotherapy that is specific for pain management. So for people who are listening, before we open to Q&A, I have one last question for each of you. If you want the audience to remember one point or something today and take away, what would that be? I'll start with Sunny and move this way.
Sure. Language for something that has no language. So thus the poetry. You'll find it on veteranscourage.org. I'll start with that. If you take away, at the core part of what I do is love, expressed in a language that's trying to describe the impossible. And if that can take that mental noise and allow the pure signal to come through, I hope that remains with you.
Thank you. Neelu?
For me, it would be that you are empowered and you have control even in the times when you think things are totally out of control and out of sync. You just have to take that driver's seat and drive along with your clinicians and make sure that they hear you. And you make sure that you tell what's important to you so that a plan can be tailored around what your needs are versus trying to follow a plan that is being layered on you. So I think that would be the one biggest takeaway, that take control of your condition.
Thank you. And Mukund?
And what I would add to this is, since we're talking about pain, I would tell both the patient and the family member that unfortunately in cancer and effects of treatment of cancer, pain is normal. It happens, and you are not any less for having the pain. And so find help from some people, whoever you trust, to help deal with it the best way you can.
Yeah, thank you.
I would also add, like, the evidence base, since you brought up CBT, which is huge and very important. Also, mindfulness based stress reduction
Yes.
is available by everybody at the hospital. You just have to ask and receive it. Tai Chi, yoga, Qigong, these are the things that are available at medical centers, and you have to just know to ask so that you can benefit from it.
Yeah, thank you. So there's resources out there. We're going to move to Q&A. And yeah, Narenji, 1 minute. But before we stop the recording, I just want to say that the recording of this will be available for, as well as a recording of the prior 3 talks that we have done. So it's available on CWC's website, it's available on our SAFAD Studies website. And this one will be available shortly. The other 2 of them are already out. The third one will go on this week, and then this will be available shortly.
So what I want to say to you is, a lot of these things are available, but there is a very big unmet need in our community. So that is why CWC now, working with all of these people, is creating Navigate Cancer program, that was being led by Vimal Solanki and supported by Prasad Saranjami. So we expect to launch it next quarter. The goal is very simple. In our community, in few areas, that has been achieved. For example, if there was a domestic violence, there's a number you call and you get the help. There's a South Asia Heart Center. Some issues you have, call them. We want to create the same kind of thing. If you have any concern about cancer, here is a number, here is a website. And what are we doing is same thing, Mukundji, what you said, is not give you medical advice, but there is somebody empathetic who will listen to you and be able to guide you in that direction. So the reason I wanted to say this to all of you is any one of you interested in this, please come forward. This is a big need in the community, unmet need. And thank you, all of you, for, and all of you will be part of it. So the goal is to make sure there is a platform where hundreds of people could reach out and we will have some help, not medical advice, just like you said. The goal is to have resources provided. Thank you.
Thank you, Narenji.